rush his time and to make sure he can get back to his beautiful bride and celebrate their anniversary. Thank you so much for taking the time. Thank you all for joining us for today's webinar, Advancing Health Equity and Addressing Medical Racism, presented by the Health Equity Collaborative. My name is Amy Hinojosa, and I'm the president and CEO of MANA, a national Latina organization, and the MANA Action Fund. MANA is a very proud member of the Health Equity Collaborative, along with over 30 national civil rights and advocacy organizations committed to advocating for solutions-based policies that address the social determinants of health that disproportionately impact our underserved communities nationwide. We're going to have a great conversation with some of the leading health equity subject matter experts from some of the nation's most influential organizations. These incredible individuals will share insights from their work and will be taking your questions. We're proud to have among our speakers Jeanette Contreras from the National Consumers League, Tammy Boyd from the Black Women's Health Imperative, Kimble from SCL Global Policy Initiative, and Jason Resendez from UsAgainstAlzheimer Center for Brain Health Equity. And to get our program started today, we are so honored to be joined by Congressman Bobby Rush. Congressman Rush is a transcendent and influential American leader who keeps his legislative and policy interests focused on the needs of his constituents in the 1st Congressional District of Illinois, with an emphasis on the most vulnerable and the communities that feel left behind. His work reflects a deep determination to bend the arc of government resources and innovation towards the needs of every American, whether they live on our nation's main streets or its side streets. It is my incredible privilege to introduce the Honorable Congressman Bobby Rush.
Good morning to each and every one of you. Amy, thank you for that fine, outstanding, undeserved introduction. I am so delighted to be here with you. I'm especially delighted, as you might be aware of, to be once again in the same company as my longstanding good friend and fellow warrior and advisor and consultant and ally and comrade in trouble, my friend Kimble, and to each and every one of you. I really appreciate this distinguished opportunity to join you this morning for what is an absolutely important and on-time discussion on advancing health equity and addressing medical racism. As you know, these issues require our all-hands-on approach, our all-hands-on deck, which is why I am certainly delighted and I look forward to hearing from such a broad array of experts who you have on your panel this morning. I am a lifelong fighter for health equity. And warrior, as a battler, as a fighter for health equity, So COVID-19, in some sense, saddened me, but it also just reaffirmed my lifelong objective that existing health equities are equities that have been too long ignored, too long denied to such an important segment of our society. Those of you who are on the panel, the news media, the experts, the establishment, apologists, they didn't tell us something that we didn't already know. We already know that healthcare is an illusion for far too many of our communities far too many of our families, our loved ones, it is an illusion. Some of us can live lives where we have not even the bare rudiments of health equity, access to the innovative powers and prowess of the American healthcare system. Time and time again, we've seen Black and brown communities left worse off in the wake of major crises, especially as it relates to our economy and particularly as it relates to our health condition. However, I'm an eternal optimist, and I'm hopeful that through more transformative legislation, followed by a parallel sense of commitment to to our action, our activities, our demonstrations, that we can somehow lessen the adverse effect of our communities and we can actually correct some of the mistaken policies of the past. One of the things that I have introduced legislatively that I am really excited about, I have a bipartisan bill, the PSA Screening for Him Act, which I introduced with Representative Larry Bouchon from Indiana. I hope that we can increase access to free screenings for individuals most at risk and for the problem of prostate cancer. I've introduced another bill that I hope that you will get behind and support. It's the Allied Health Workforce Diversity Act. I sponsored this with a Republican by the name of Mark Wayne Mullen. And I hope that we can increase the diversity of healthcare providers being recruited, educated, and who graduate from healthcare institutions, including physical, occupational, and respiratory therapists. And that's a problem that is so significant. And there's a bill that even today I am introducing. It's called the Communities Act that I'll be introducing in the next few moments. And I hope that through this, to the passage into law of this Communities Act, that we can ensure that doctors who we rely on, doctors who can practice in medically underserved areas, I hope that these doctors are incentivized to come and go to their school and practice in our communities. And we want to make sure that they are provided with student costs, that they are not weighed down by student debt. I believe that if we're going to ever realize access to health care in a fair way or in a way that provides equal access to health care, then we must provide free education. No string, no cost attached. And the only obligation that we will lay before these participants in this free health education for doctors is that their health care will be, the cost of their health education will be free. And so I hope that this bill will get your consideration and get your support. My commitment to free healthcare, to healthcare for us all, to making sure that the advanced, innovative healthcare system in the United States is provides access to all regardless of ability to pay. It's long standing, and in my early adult years, I sponsored and created an organization of free health clinic, the Spurgeon J. Winners Free Health Clinic here in Chicago. And I belong to an organization that created a nationwide network of free health clinics serving in poor and underserved communities. So I'm not a new enthusiast. All of my adult life, all my public life has been committed to making sure that health care is provided to all Americans. I believe that, as I did in the 60s, that the only requirement that should be required of anyone seeking health care in our nation should be that they are indeed sick. They're worthy, and the only thing that we are looking for them, the only requirement is that they be sick. So with that said, I am delighted to be here with you this morning. I know that you got a lot of important work to do, and thank you for this invitation. And I'm just so delighted just to be among you and to be so honored by you. Thank you so very, very much.
Thank you so much, Congressman Raj. We are appreciative of your hard work, your determination, your leadership, and you are absolutely right that the health experts didn't have to tell this group of folks about the social determinants of health when COVID hit. We knew what was impacting our communities, and we know the way forward, and we know with leadership like yours and partners at the table like you that we'll be able to get this help over the line to the folks who really need it. And so we look forward to that work, and we look forward to partnering with you on those efforts. So thank you very, very much.
Thank you so very much. All right. Bye-bye.
Bye-bye. And now I'd like to welcome our distinguished panel for today's discussion. We've got Jeanette Contreras, Director of Health Policy for the National Consumers League, Tammy Boyd, Chief Policy Officer and Counsel for the Black Women's Health Imperative, Kimble, Executive Director of the SCL Global Policy Initiative, and Jason Resendez, Executive Director of the UsAgainstAlzheimer Center for Brain Health Equity. We will be introducing each of our speakers to tell us about their organizations, the work they're doing in the health equity space, and any potential legislation they would like to uplift. But to set the stage, I'd like to give you a little background on the Health Equity Collaborative. We're, again, a coalition of over 30 national civil rights and advocacy organizations committed to advocating for solutions-based policies that address the social determinants of health. The coalition came together earlier this year to draft a letter to the Biden administration and to Congress, stressing the urgent need for health equity to be made a priority. Underserved communities, as you heard from Congressman Rush, face the brunt of impacts due to the COVID pandemic, and we're still struggling to get our communities vaccinated. We wanted to make a clear statement that any solutions to the pandemic and other large-scale policy related to healthcare can only be successful if these social determinants of health are solved for as well. Otherwise, they only represent Band-Aid interventions. Among the critical points we addressed are ensuring an equitable response to COVID-19 and pandemic preparedness, acknowledging and addressing workplace inequities, prioritizing racial equity and support for underserved communities, establishing a blueprint for mental health reform, combating food insecurity and nutritional disparities, making social determinants of health a national imperative, addressing gender and race pay gaps, expanding healthcare coverage for all Americans, expanding access to home and community-based services, increasing diversity in clinical trials, solving the maternal health crisis, developing workforce diversity in healthcare, promoting value-based treatment in clinical care, supporting breakthrough medical technologies and innovation, collecting, analyzing, and releasing demographic subgroup data. And we've been incredibly encouraged since our letter was sent out to see that racism was actually declared a public health crisis as one of our requests. We can put the link to that letter in the chat for those of you who haven't been able to see it, and you can also find it on the Health Equity Collaborative website, healthequitycollaborative.org. What we know, however, is that the issues are broad and have nuance from community to community. This is why we wanted to create a big tent coalition to invite a broad group of advocates to play a role and uplift these nuances, as well as the issues that impact all of our underserved communities, whether Black, Brown, LGBTQ+, the disability community, and more. So we're honored to be joined by a few of our colleagues from the Health Equity Collaborative to talk about their organizations, their work in the health equity space, and to hear about any potential legislation they are championing. Once we hear from each of the panelists, we'll begin the Q&A, and we will take questions from the audience. So please feel free to share them in the chat box, and we'll get to as many questions as possible. And now I'd like to begin introducing our distinguished panel of experts. First, I'd like to welcome Jeanette Contreras, Director of Health Policy for the National Consumers League. Jeanette, you have the floor.
Thank you. And I'm just going to wait one moment while we get the slides up. And I just want to say thank you so much for the invitation. This is such an honor to be a part of this panel. I'm going to start out by telling you a little bit about the National Consumers League. Next slide, please. NCL was founded by two social justice reformers. A lot of people don't know this. Jane Addams is credited for playing a significant role in passage of the first federal child labor law in 1916 and was the first woman to receive the Nobel Peace Prize in 1931. She and Florence Kelly, both pictured here, were among the founding members of the National Association for the Advancement of Colored People. Florence Kelly dedicated her life to fighting for better conditions for workers and equality for women and African Americans. I have the privilege of leading health policy work here at NCL, and I often hope that I make them proud. Next slide, please. Because of our history of advocating for maternal and infant health, we were compelled to convene the Preterm Birth Prevention Alliance, a coalition of maternal and women's health advocates who oppose the proposed market withdrawal of 17P, which is the only FDA-approved drug to help prevent spontaneous recurrent preterm birth. The preterm birth rate among Black American women is 49% higher than the rate among all other women. And we are calling for the FDA to consider additional evidence and more diverse medical research that adequately represents the experiences of women and newborns of color. The withdrawal of 17P from the market would leave women of color with no FDA-approved treatment options to prevent preterm birth. Next slide. In our work to ensure equality for women, we support policies that encourage reproductive justice. We believe that all FDA-approved contraceptives should be fully covered by insurance without cost sharing or copays. NCL Executive Director Sally Greenberg is hosting a webinar on this topic this afternoon. We also support permanently lifting restrictions on access to the abortion pill mifepristone. In April, the FDA enacted a temporary lift on restrictions to allow mifepristone to be dispensed by mail after a telehealth visit for the duration of the COVID-19 public health emergency. And here we are in June, looking at life going back to normal, and these women will again lose access. Mifepristone has been used in the US for more than 20 years to safely end unintended early pregnancies and to treat early miscarriage. The FDA has placed particular restrictions on mifepristone when it is used for pregnancy termination. We argue that if it is safe enough to access via telehealth during COVID, it should be safe enough afterwards. We also applaud the extension of Medicaid and CHIP coverage to up to 12 months for postpartum care to birthing people, which was included in the American Rescue Plan Act. This policy is critical to achieving a birth justice framework to support our most vulnerable communities. States have the option to adopt this policy, and so far only a handful of states have. We want all women to have access to the same health benefits, regardless of what state or what zip code they live in, which is clearly a social determinant of health. Next slide, please. Ensuring an equitable response to COVID-19 is a priority. NCL has long advocated for access to safe and effective vaccines as life-saving public health interventions. In fact, NCL's founders played a key part in mitigating a smallpox outbreak towards the end of the 19th century. And since then, vaccine confidence, education, and safety has been a core part of our work. My colleague Nisa Shafi and I have both had the privilege of testifying before the CDC and FDA vaccine advisory committees during the development of the COVID-19 vaccines. In our testimonies, we applaud the agencies for their transparency and coordination to ensure the safety and efficacy of the emergency use authorizations for COVID-19 vaccines, tests, and treatments. We called on the FDA to ensure racial and ethnic minority groups were adequately represented in COVID-19 clinical trials, and applauded their ongoing surveillance through the vaccine adverse event reporting system. We called on the CDC to prioritize vaccinating essential health workers and communities hardest hit by the pandemic. Last week, I submitted a somewhat personal written testimony on behalf of NCL and as a mother of 2 boys, ages 8 and 9, in support of granting emergency use authorization for the COVID-19 vaccine in pediatric populations. The absence of a vaccine for school-aged children will not only lead to continued transmission. As they return to school in the fall, we may see a spike in pediatric cases. I will be the first in line to vaccinate my children when possible. Next slide, please. One of NCL's bedrock principles is that consumers get a fair deal. NCL has been raising awareness of the role that pharmacy benefit managers play in the rising cost of prescription drugs. Consumers are unaware that these middlemen are supposed to negotiate better deals for patients. PBMs contract with employers and insurance companies to cover a large number of individuals, and then use their leverage to negotiate lower prices from drug manufacturers. Unfortunately, they're using their size and market power to increase their own profits rather than deliver discounts to consumers. Patients shouldn't have to choose between buying groceries or their medications. Cost is always a factor in medication non-adherence, which only leads to greater health disparities. West Virginia recently passed a law requiring PBMs to share some of the discounts and rebates provided by drug manufacturers with patients. Other states like Minnesota and Colorado are also advancing bills to ensure transparent competition. Policymakers need to step in to ensure PBMs pass the savings on to consumers as originally intended. With that, I'll conclude. Thank you for your time. I look forward to the Q&A discussion.
Thank you so much, Jeanette. And now I would like to introduce to you Tammy Boyd, the Chief Policy Officer and Counsel for the Black Women's Health Imperative. Tammy, take it away.
Thank you, Amy. Thank you, and I'm glad to be here today. So first to start, for many of you who may not know about Black Women's Health Imperative, we are a national nonprofit organization dedicated to advancing health equity and social justice for Black women across the lifespan through policy, advocacy, education, research, and leadership development. And the organization identifies the most pressing issues that impact the 22 million Black women and girls. Next slide. And so one part of the way that we have outlined the way we look at health equity and address it, we released, this is the second iteration, we've released the National Health Policy Agenda. And in the policy agenda, there are 5 pillars. The first pillar is around access to quality and affordable health care, where you'll find, for example, your reproductive health issues, which Jeanette just spoke about, Medicaid, ACA. Also, the second pillar is around equitable responses to public health emergencies. The third pillar is around sufficient diversity in clinical research. The fourth pillar is around increasing funding to support HBCUs. This year we also added a 5th pillar, which is around social justice issues. Next slide. And so a part of the policy agenda, we also created a advancing health equity campaign. Early on, during the transition period, we pulled together about 30 to 40 Black women groups, or groups that are Black women, Black-led groups that are focused on healthcare issues that impact Black women. And we met with the Biden administration, and we created a campaign. And the campaign was really focused around policy reform and advocacy, and really brand building, and building awareness around some of the key issues that span from uterine fibroids to breast cancer to cervical cancer. Last week, we just launched a campaign with Sierra to raise the importance of screening for cervical cancer. We did one earlier during the pandemic around the need to continue to have your mammograms to continue to get screening. We did that one with Mary J. Blige. And so sometimes we also utilize, key influencers to really elevate some of the key issues impacting Black women and girls. Next slide. So what I'll do the next few slides quickly, just talk about some of the key programs that we have at Black Women's Health Imperative, where we really do a deep dive on equity. And one such initiative is the Rare Disease Diversity Coalition, which we are very proud of. And this really started during the pandemic, and where we saw there became a concern of patients who had rare disease, just what did access look like for them? And so, next slide. And so we created the Rare Disease Diversity Coalition to really address the challenges faced by rare disease patients of color. It's a multicultural initiative. It includes, we decided to start with African American, Native American, Hispanic, and also the Asian Pacific Islander community. And we wanted to bring all of those communities together. But in addition to that, we also wanted to bring a variety of key stakeholders to come up with evidence-based solutions to alleviate the burden of rare diseases on communities of color. But at the table, we have rare disease experts, we have health and diversity advocates, and we also have formed a really excellent relationship with industry leaders as well. And all these groups coming together at the table to really, again, come up with key solutions to address the burden of rare disease patients with color. Next slide. And this is just some of the groups that are on the steering committee as well. Amy is one of our key folks as well, who's also on our steering committee, as well as many others as well. Next slide. Also, we released an action plan and really focused on charting the path forward for equity in rare diseases. We also developed 4 work groups, well now 5. So the first work group we have is around correcting delays in diagnosis and treatment, improving. Second work group is improving patient and provider education and engagement. And this is a piece that initially we started out as the patient and provider education, but we really saw that there was a need to, again, make sure the patient is at the center. So we also have patients, so we created a separate patient work group, but then also we go horizontally where patients also participate in each of the work groups. The third work group is improve the state of research and clinical trials. And then the fourth work group is around advocating for government policy. And again, improving the patient and provider education engagement. We have the fifth work group, which we recently created, which is around patient engagement. And some of the clinical trials diversity is one that is definitely, we're working legislatively on the Hill with Congresswoman Kelly's office in terms of introducing legislation around clinical trials. We plan to also weigh in on the CARES draft as well. We are also looking at telehealth and how, particularly during COVID, we saw how telehealth can be used for rare disease patients, and looking at permanent solutions of telehealth and its impact on rare disease patients. In the clinical trials aspect, we also are looking and creating a program around addressing the number of rare disease researchers and medical students that come from communities of color, but to focus on rare diseases. But we're doing a deep dive. I won't go through all the recommendations, but the groups met last year and over the summer and over last summer, and we came up with, they came up with about 75 recommendations. Within this action plan are about 11 recommendations that focus on these 5 key areas. Next slide. We also have a sickle cell diversity advisory council. And this group it has some of the similar members as the rare disease diversity group. But for example, we have the Black Nurses Association. Again, we also have industry at the table, such as bio, also biotech companies, again, like Bluebird Bio. We have the president of Sickle Cell Disease Association. As well, and coming up with ways to really build upon the 2018 legislation that was passed with Senator Scott and Cory Booker, and also Danny Davis on the House side. But we're working on the second iteration of sickle cell disease legislation. Next slide. And so another program we also are working on is Reclaim Your Wellness. And this really goes into addressing obesity and looking at the continuum of care. So for example, we also have a diabetes prevention program, but we're looking at on the continuum, diet, exercise, but on the other end of the spectrum is obesity and bariatric surgery. And so we are specifically legislatively advocating for the Medicare coverage of anti-obesity medications. Right now, bariatric surgery on the other side of the spectrum is covered, but there is no coverage for anti-obesity medications. So this is one that we started in January. We're going into our second phase of Reclaim Your Wellness, and we're excited about it, but it's to address obesity, again, to address the disparities. Black women, 80% of Black women are either overweight or obese. And so that is a key area that impacts our community. And quickly, as you know from COVID, one of the underlying causes that where we saw severe complications of COVID had to do with obesity. So really addressing many of these inequities and many of these disparities are really pivotal and key to what we do at Black Women's Health Imperative. Next slide. And thank you. You can find more information at www.bwhi.org. Also, the Rare Disease website is www.rarediseasediversity.org. Thank you.
Thank you so much, Tammy, and thank you so much for the work that the Black Women's Health Imperative is doing. I'd now like to turn to the gentlemen on our panel, starting with our friend Kimble, Executive Director of the SCL Global Policy Initiative. Kevin, take it away.
Thanks, Amy. So it's good to be here this morning and to talk about one of my favorite subjects, which is, health inclusion and health equity. I'm the DC Bureau Chief for the Southern Christian Leadership Conference, and in that position, I'm also the Executive Director of the Global Policy Initiative. SCLC, for those who don't know, is the civil rights group created by Dr. King in the mid-50s, which was the leader of the civil rights movement through that time period where we went through the Voting Rights Act and the Civil Rights Act. One of Dr. King's big philosophies was, economic inclusion. Everyone thinks of him from voting rights and the marches on Washington, but he actually was assassinated on an economic pilgrimage to Tennessee. And some 50 years after his over 60 years after his death, we are now looking at a situation where the economic situation in America for African Americans is worse than it was before the beginning of that process. And he predicted this in his conversations. So we have spent a lot of time focusing on the economics, as we're talking about the social determinants of health. The economic standing of African Americans is such that if we will never have economic health inclusion or health equity if we don't have economic parity. So we spend a lot of our time, we work on these issues with you guys, and we're so happy to be a part of this, is why we signed up with you, because we know that the work you do is important. And if we're lucky, we'll be able to uplift people to the point where they can actually take advantage of the advances in medical care. And Dr. King has a quote that I love to use in these situations when the arc of history bends towards justice. The corollary to that is it bends towards justice because people lay their bodies on the line to bend it in that direction. The corollary to that is a lot of people push in the other direction. So it's always hard to get justice in these situations. And we are looking at a circumstance now where even as all this efforts being pushed towards equity, the forces of intolerance are pushing back against us, right? So in the Sixth Circuit, there's been 2 court cases that have actually come out and denied or reversed efforts to actually push forward on economic inclusion or inclusion for African Americans and underserved communities. So as much as we're working in this area, we can't forget that there's a whole long line of things that have to be done for us to take advantage of the equity. So from that, I'll go forward a little bit. One of the things we've been fighting against or very concerned about is ICER and QALYs in the pharmaceutical drug pricing space, because those all make judgments on the quality or value of someone's life. Well, if African American wealth is going to be 0 by 2052, then obviously we'll never get the right drug pricing schemes to help us take advantage of the pharmaceutical benefits. We're also pushing very hard to include the vision and dental benefits in the Medicare, which is being considered in reconciliation. So those are things we care about, but for our communities, even if you get to that level, pharmacy deserts, hospital deserts, and food deserts are all issues that cause us not to have access to any of the benefits that we are actually able to take advantage or able to secure. Congressman Rush came on and great guy. I mean, I've been very lucky in my life to spend a lot of time with a bunch of civil rights leaders over the last 50 years, and he's one of them. And the passion which they still bring to this fight is encouraging and uplifting, because he's still talking about PSA screenings and allied health, diversity and the Communities Act. We're trying to push forward this agenda, and we are, every time we turn around, there's someone fighting back against that, right? So we're looking at joining people like you, and we're part of a lot of different coalitions just to push forward on a situation where we can take advantage and not see whatever gains get made, eliminated, because that will happen. I mean, that's we have the advantage or disadvantage of SCLC of being able to see, the highs and then the retrenchment, right? And so that is one of the things. So a lot of times we're the skunk in the party, because we're like, yeah, this is great. There's a lot of energy right now, but for every gain we make, there's 10 people trying to take that back from us. So we encourage people to not just look at the individual tactics or the individual policies, but the overall landscape and fight for that. And that's where I think it's where SCLC's biggest strength comes in. It's not I'm not a healthcare expert, I'm not a pharmaceutical expert, but we are social justice and change experts, and that's what we're fighting for. And so I look forward to hearing the rest of this conversation. And obviously this panel is great, and Ethical Collaborative is great. Amy, you guys have done a good job of bringing some of the best talent in. And so thank you for having me.
Thank you. We're so privileged to have you, Kevin, and SCLC as part of the efforts. And thank you for your long-term commitment to, as you said, bending the arc of justice in the direction that helps all of our communities. And so I'd like to introduce now, last but certainly not least, our friend Jason Resendez. He's the Executive Director of the UsAgainstAlzheimer Center for Brain Health Equity. Jason, it's all yours.
Great, thanks so much, Amy. I'm really excited to join this group and to really round out, I think, the way that we have to think about health equity across the lifespan. So amazing work being done by my colleagues at the earlier side of that spectrum. And we're really focused as an organization to promote brain health across the lifespan. So Us Against Alzheimer's is a patient advocacy and social impact-based organization that is disrupting the aging space to push us to think more critically about how we can promote brain health across the lifespan. In order to do that, we have to center equity, what we call brain health equity. This is for A couple reasons. One, we know we're an aging society. This is something that COVID has demonstrated in a lot of really tragic ways in terms of the disproportionate impact of COVID-19 on older Americans, particularly older Americans juggling multiple chronic conditions. But also, we've seen a drop in birth rates because of COVID. So, this acceleration of our aging society will only increase across the US and then also nationally. And when we think about those demographics that are aging at a higher rate, those are people of color. I always think about in my work and previous roles in organizations like Unidos US and LULAC, and we had always thinking about the Hispanic market, right? And what did this mean? And people that are interested in advertising, things like chips and sugary sodas, et cetera. There's the hot market, the demographic market, the young market. But the flip side of that is we're becoming an aging market, which is important, right? So it's showing that we have really improved health outcomes and we are among the fastest aging populations in the US. Unfortunately, though, we have to better prioritize equity and health outcomes and quality of life at the end of that spectrum. And right now, Black and Latino Americans, unfortunately, are at a higher risk for Alzheimer's for a number of reasons. One being advanced age. Advanced age is the #1 risk factor for Alzheimer's and related dementias. And as I mentioned, we're fast growing older adult, 65 and older demographic. Two is also a number of comorbid risk factors, including higher rates of diabetes, higher rates of hypertension, a lot of the things that my colleagues have talked about and their amazing initiatives to address those disparities, all have a compound effect in increasing risk for Alzheimer's and related dementias in later life. At the same time, there are risks related to social determinant factors that shape dementia risk. We're learning more and more about this every year. So there's a biological component, but there's also a powerful social determinant and social economic component as well. And Us Against Alzheimer's is focused on ensuring that the field and the healthcare system more broadly is considering how these factors are interconnected. And pushing us to think about solutions that are interconnected, intersectional solutions that are looking beyond just the healthcare system and the laboratory to address the growing impact of Alzheimer's on communities of color, but then also on the nation more broadly. So 3 issues that we're very much focused on to advance what we call brain health equity. 1, the importance of early detection and diagnosis of Alzheimer's. So as I mentioned, Latinos are 1.5 times more likely to develop the disease, Black Americans 2 times more likely. By 2030, nearly 40% of all Americans living with Alzheimer's will be Black or Latino. Despite a higher risk, these communities are far less likely to receive an accurate and timely diagnosis compared to their white counterparts. That means less time to plan for care. That means less time to access potentially effective treatments. And this year we have more treatments than ever in the Alzheimer's space available to patients and to families. But if we're not receiving an accurate and early diagnosis, we're unable to take advantage of those options. We're unable to take advantage of exciting science around risk reduction, things that we can do to actually reduce our risk of developing Alzheimer's in later life by taking action on things like controlling our risk for diabetes and hypertension. Those messages get lost if we're not able to accurately assess and detect this disease as early as possible. It also means less opportunity for enrolling in vital clinical research. Latinos and Black Americans and other people of color make up a dismal proportion of individuals enrolled in Alzheimer's research. In fact, less than 10% of all federally funded Alzheimer's trials are made up of Black and Latino and other people of color. Less than 10%. And that's our tax dollars, our federal funding going to support that research, and yet we make up only a small fraction of the participants in those trials. And so early detection is absolutely critical to advancing those inequities. So we're big champions of a piece of legislation called the Change Act, HR 3354 and S1692, which would direct CMS to point providers to using validated assessment tools identified by the National Institute on Aging during the annual wellness visit. As part of the annual wellness visit, and thanks to the Affordable Care Act, individual Medicare beneficiaries have access to a cognitive assessment free of charge as part of the annual wellness visit. But right now, providers are using clinical observation, provider observation to satisfy that requirement. We think that's not good enough. Less than 40% of individuals are told by their provider that they have Alzheimer's or related dementia, even if it's been diagnosed by their provider. So there is a vital need to improve detection. We think this is an easy and important fix to better empower providers to identify the tools that have been validated by the National Institute on Aging to make that diagnosis. Second, we are big champions of investing in Alzheimer's research and public health infrastructure. A lot of the communities that we're talking about today are in places where there's limited access to care, limited access to specialty care, and certainly limited access to research centers. We partnered with the Urban Institute and the National Minority Quality Forum in 2020 to do an analysis of the top 25 US counties most impacted by Alzheimer's among Black and Latino Americans. And what we found is that in those counties with the highest prevalence of the disease, we saw worse social determinant outcomes compared to the counties with the lowest prevalence of the disease among those communities. That means that families in those counties have higher rates of uninsurance, have higher rates of poverty, have fewer access opportunities to access exercise in the built environment. And all these are critical factors for reducing and managing brain health reducing Alzheimer's and managing brain health across the lifespan. So we see through this analysis that these highly impacted counties are under-resourced. We also found that there are very few research sites, federally funded research sites in these communities. In fact, 4 of the top 10 counties impacted by Alzheimer's among Latinos are in South Texas. Yet in the state of Texas, there's not a single federally funded Alzheimer's disease research center. These are the top tier research centers that our nation funds to address Alzheimer's and to provide better resources through research. There's not a single one in the state of Texas, despite that high impact among communities of color in the state. We see that in other places like Southern Florida, for example, highly impacted by Alzheimer's, yet very limited research infrastructure. So we're advocating for a $289 million investment in Alzheimer's research at NIA to be able to address this kind of infrastructure gap. We're also advocating for a $60 million appropriations for the CDC's Alzheimer's disease and healthy aging program, which is our nation's only public health program geared towards addressing the impact of Alzheimer's at the state level and in high impact communities as well. We have to think about this not just as a issue of research, but also as an issue of public health. As we know, more and more every year, there's growing science around our ability to reduce risk for Alzheimer's and related dementias. And that means public health response could make a big difference in addressing the trajectory of Alzheimer's over the coming decades. That curve of nearly 40% of Black and Latino Americans being part of the Alzheimer's population by 2030 could be bent if we invested in a stronger research and public health infrastructure. And then lastly, we have to think about how brain health is interconnected to wealth and economic opportunity. So we're big proponents of establishing a national paid family and medical leave policy. We're very excited about the administration and some bipartisan interest in establishing an improved care infrastructure in this country, which is absolutely critical for the Alzheimer's community. There are 16 million individuals providing Alzheimer's care at a rate of over 18 billion hours of unpaid labor in this country. Oftentimes, Black and Latino caregivers are disproportionately impacted by those numbers. These are individuals who are more likely to be working while also providing care. And so without a national paid family medical leave policy, we're forcing these individuals to leave the workforce to provide that care. Or making it harder for families to navigate care while working, which also means that it's harder to navigate a complex diagnosis. It's harder to navigate multiple physician's appointments, for example, which unfortunately are part of the reality about the Alzheimer's journey. So by establishing a national paid family medical leave policy, we can advance economic and racial justice in how we support caregivers, but we can also improve access to care and treatment by making that journey just a little easier, by ensuring that folks don't have to worry about losing their job if they're going to accompany their parent or a loved one to a doctor's appointment or to a provider's appointment while navigating that care. So again, really excited to be part of this conversation, to bring the importance of brain health into the framework, to really think about improving early detection through the CHANGE Act, improving infrastructure investments in our national research and public health response, and also by promoting economic and racial justice through a paid family and medical leave policy. Thank you.
Thank you so much, Jason, and thank you for the work that you do at Us Against Alzheimer's. It's truly transformational. And I know the work, it feels like it's only just beginning and we have a long way to go, but we've also come a long way. So for those of you who are in the audience, we've got a couple of minutes for questions. So if you've got burning questions that you'd like to ask, please put them in the Q&A or the chat boxes and we'll try to get to them. But I really want to get to this topic of racism with our panelists, right? In the last few years, as it seems to happen generationally, unfortunately, the country starts to have more and more conversations about racism and how we reckon with that in our national discourse. And we often think of racism in the context of overt actions and words, but really, I think, as advocates, I think this, that really it's about how racism manifests itself in our systems, right? And in this healthcare space, racism isn't often spoken of. So I'd love if, and this is open to any of the panelists, can you talk about how racism is manifested in our healthcare system and how we need to address it?
I can take a crack at that one. So for example, when we look at sickle cell, which is we have the Sickle Cell Diversity Alliance, and one aspect that we look at, for example, is pain. Often you find that sickle cell patients, they go in related to the pain they feel. And so oftentimes and even beyond that, and for other disease states, we talk about implicit bias. And so oftentimes, studies show that Black women, their pain isn't taken as seriously, or they are seen as drug seeking. And so that is one of the areas that we're trying to address Black Women's Health Imperative, and we're happy to be a part of the Health Equity Collaborative and to be with partners of all of you on this panel to address how do we, addressing implicit bias, but we're working to look at developing focus groups to really address that issue. And then also Jeanette talked about maternal health. I mean, we're also looking in the maternal health space. We've all heard the story with Serena Williams. She continued over and over to say, hey, I know something's wrong with me, when she was having her child. And if she didn't continue to push and felt empowered to do that, and she's like, great celebrity and all-time athlete, even she faced the same what we call as implicit bias, not taking many of her, what she's saying, seriously.
Yeah. And, Kevin, you even mentioned in your remarks, and I think Jeanette mentioned it as well, whether it's the pricing on pharmaceuticals, right? And whether it's the pharmacy benefit managers or the calculations that are used, for example, in the 340B program, they never take into account communities that are in abject poverty, right? Or communities that struggle to make ends meet. Can you talk a little bit about that and how that manifests itself?
Sure. So I'll take that. Two things came to mind when you asked the question, and I'll address yours first. The first thing you said is that as we look at these, because of the way the communities are segregated, first, there's a big segregation problem. And so the hospitals and the patients, they're in Washington, D.C., where I live, if you live in Ward 7 or 8, there's no hospital for 4 miles you have to go, but if you're in Ward 1, there's like 5 hospitals. So there's just this huge, so all those things devalue you in the overall scheme of things if you're talking about ICER and these other drug pricing schemes, or the ability to take advantage of 340B if you're not in the right place, if there's no pharmacies or the hospitals. So it does really isolate you, the isolation, which is a function of overt and sometimes covert racism. But here's the one that really bothered us, coming out of this COVID. 52 billionaires were created during this process, but as far as we could tell, very few, or to no African Americans, particularly, maybe it's true for Hispanics too, I believe, got contracts for contract tracing, or got contracts to sell PPE, or got contracts. People were dealing with scammers rather than dealing with minorities in the business sector. And even though that sounds not healthcare related, but if people don't see you as part of the system, then you're always left out when it comes to everything. And so that's one of the reasons we fight so hard to make sure we're included in the infrastructure of this system, because that's the only way you're going to actually get the responsiveness that you need.
Absolutely. And, I know that we, as part of the Health Equity Collaborative, we all feel that this is really our moment, right, to step forward and really speak on behalf of our communities. And maybe Jason or Jeanette, you can take this question. Why is now the time? Explain it to our audience. Why is this the moment where it's so important for advocates to speak up on behalf of our underserved communities?
Yeah, I'm happy to start. I mean, I think every moment is that moment, I think. And, one of the things that has always inspired me is Dolores Huerta, a quote that she says, every moment is an opportunity, every conversation is an opportunity for organizing. And I think that that's true. I think what COVID has shown us is the importance of that philosophy, because the stakes are so high. When we think about the precision at which health inequities, and COVID is the latest example of that, prey on communities of color and under-resourced communities, it's alarming. And this, I think, was the first time that it really garnered national attention in the way that it did. I kind of compare COVID to Alzheimer's. Alzheimer's is like COVID, but it's happening in slow motion over the course of decades. And COVID, was in a flash upended families and our nation, our economy in just a matter of months. And it was, those Black and brown bodies piling up that really show us as advocates how essential this work is and what the price of inaction is. So, I mean, the time is now, because we continue to see who pays the price when we're not acting on the recommendations that we've outlined. I think that, we have to do more to ensure that what we've learned during COVID is put into action. We've all outlined a couple of important legislative opportunities. That's just a start. That's not going to transform the system. I think the other thing that happened, were just the massive showings of racial justice protests, and a new consciousness around how we treat Black and brown people and other people of color in this country in a way that, is on camera and up in front in our public consciousness. So the time is now, because the price is so high.
Yeah, thanks, Jason. I'm going to add that in the work that we do to work on vaccine confidence, it's evident, right, that the systemic racism and all these medically underserved communities have this, legitimate distrust of, the people coming into their communities. So we see it in the vaccination rates, we see it in vaccine confidence, that, yeah, these communities have been neglected for far too long. And, it's going to be a long, hard road to rebuild that trust, right? So that's what we see. And, our work at the Consumers League is so informed by our founders and its history. And we as an organization we support reparations. We see and acknowledge racism as a public health issue. So I definitely look forward to continuing to work with the Health Equity Collaborative and everybody on these issues moving forward.
Well, thank you. And we're so grateful to have this panel of experts, and we could continue this conversation for hours more. But unfortunately, we're a little over time. So if you will help me thank our wonderful panel of speakers, Tammy, Jeanette, Kevin, and Jason, and special thanks to Congressman Rush for joining us, even on his anniversary. We appreciate him and all of his hard work. And many thanks to all of you for joining us for this conversation. Our hope is really to open these lines of communication with and offer our Health Equity Collaborative member organizations and experts as resources in your work. This group will continue our advocacy efforts, and we hope we can enlist you as partners in the effort. We have an opportunity to make great strides for all of our communities, particularly the underserved, and we look forward to being part of that good work. So thank you again, and have a safe and healthy holiday weekend, and thank you for joining us.